Hello, my name is Dr. Murray Brown. My area of specialty is equine surgery. My task today is to give you an overview of equine surgery. The topics that I'm going to cover today and the time allotted are listed here. First of all, I'm going to give you an overview of surgical colic. Then we'll talk about some of the upper respiratory problems that require surgical treatment. And we'll talk about some of the more common lameness and orthopedic problems. And then we'll discuss a couple of the reproductive surgery complications. And then I'll end with an overview of granulomatous skin lesions. So first of all, we'll get into a discussion about surgical colics. And I think it goes without saying that before you do surgery on a horse with colic, obviously you've got to examine the horse and make that determination. And first of all, you would look at the horse's vital signs: temperature, pulse, respiration, mucous membranes. And the obvious intent of this part of the exam is to see what the horse's general condition is like, what its cardiovascular function is doing. A horse that has an elevated pulse rate may have that elevated pulse because it's in pain, or it may be a result of hypovolemic shock, and it's up to you as the veterinarian to try to make that determination. The evaluation of the mucous membranes certainly is going to help give you some feel for peripheral perfusion, and this is the sort of information that you're going to need to have to determine whether or not the animal needs to go on intravenous fluid therapy. Auscultation of the abdomen is another important part of the examination, and this is something that you should be very systematic about. I always start in the same place. I usually start high in the flank and work my way ventrally on both sides. And the thing that you're trying to evaluate here is whether or not the peristaltic waves within the abdomen, first of all, are even present. And you're trying to get some impression for how well organized and functional they are. And this, of course, gives you important information about the status of the intestinal tract. Rectal examination is another part of the exam, and what you're looking for here, of course, is the position and size of the various pieces of bowel within the abdomen that you can reach. Remember that you should never be able to palpate small intestine on a rectal exam in the horse. If you can, that is an abnormal finding, and that's an indication that the small intestine is involved in the problem, and your treatment would be directed appropriately. Some things that you should be able to palpate on a rectal exam would be the caudal edge of the spleen over on the left side of the abdominal cavity. You can usually palpate the left kidney, and of course the nephrosplenic ligament, which joins the left kidney and the spleen. You should be able to palpate the pelvic flexure, the large colon. You should be able to reach several loops of the small colon as well as the cecum. And so these will become important landmarks and reference points while you do that examination. Another thing I think that's worth mentioning is that when you do the rectal exam in the horse, obviously a large part of the cranial abdomen is going to be beyond your reach, and so you're not going to be able to get information about that on your rectal exam. It's important to pass a nasogastric tube during your colic examination, and this is not only for therapeutic reasons, but you can gain some very important diagnostic information by passing a stomach tube. One of the first things that you're going to check for is to see whether or not you can get gastric reflux. And if you do, that's an indication to you that there's either an obstruction of the small intestine or at least an ileus of the small intestine. And so it would not be useful to administer any medication through the stomach tube, because it's just going to sit in the stomach and probably add to the horse's discomfort. Abdominal paracentesis may give you considerable information about the health of the inside of the abdominal cavity. As you look at the peritoneal fluid, it should have a clear sort of straw color to it. If you examine that fluid and find that the protein level is elevated, one of the things to keep in mind is that elevation of protein is one of the first things that occurs when there is compromised bowel within the abdomen. Elevated cell count may be an indication that there has been damaged bowel, or it may also indicate that there's an infectious or inflammatory process such as peritonitis going on within the abdomen. I should mention as well that doing an abdominal paracentesis is not without risk. If you do penetrate the bowel, it's possible that you'll cause contamination of the peritoneal cavity and may result in some peritonitis from that. So that's something to keep in mind as you do your exam. One of the things that students always struggle with is the question, how do you decide whether or not to do abdominal surgery on a horse that has colic? Well, in many cases that decision can be quite difficult to arrive at, but there are some fairly reliable indicators of a surgical colic. The most consistent one is the evidence of persistent pain. So you've got a horse that you've treated with all the analgesics that you have available, and in spite of that, the horse continues to exhibit violent pain. It's important that these animals be anesthetized for surgical exploration, because they can be quite dangerous not only to themselves but to those that are working on them. And so intractable pain is probably the most reliable indicator that you should go to surgery. Another indicator would be a rectal exam that tells you that there is a displacement of bowel that is not going to correct on its own. For instance, if you feel large colon between the right body wall and the cecum, there shouldn't be anything there, and so that would be a good reason to do surgery. If you were to feel an enterolift in the intestine, that would also be a definite indication to go to surgery. However, I would make the comment that frequently your rectal exam is not going to be quite that definitive in making that determination, but obviously it is helpful in most cases. Another possible indication for taking the horse to surgery would be a situation in which the animal has been treated medically for several days and you don't seem to be achieving any improvement in the animal status. So you've got an animal that may not be eating or may not be passing feces or continues to have low-grade pain, and you don't seem to be making any progress, then you probably should make the decision to take the animal to surgery to try to find the underlying cause. Now I'm going to give you a very quick review from your dim distant days in gross anatomy about the peculiarities of the horse GI tract, and that some of these peculiarities that make the horse subject to some of the surgical problems that it has in the gastrointestinal tract. Just to sort of take you through the GI tract as a piece of ingesta would go through, this white object that you see that's labeled number 4 is, as you know, the stomach. So the ingesta passes from the stomach through the duodenum in a caudal direction, passes from the right side of the horse over to the left around the root of the mesentery, and then continues as a jejunum, which is this long segment of bowel depicted here. The jejunum continues as the ileum, which is distinguished by this small band that you see evident here. Actually, it's quite a large band, and this is the ileocecal ligament, and that's the indicator to the surgeon that that's the beginning of the ileum. The ileum continues and passes into the medial side of the base of the cecum, so the ingesta is mixed within the cecum before it moves on into the right ventral colon, passes through the right ventral colon to the sternal flexure, then through the left ventral colon, then through this area here, which is referred to as the pelvic flexure. And you'll notice here that the diameter of the colon is markedly decreased at this area, and so that is going to make it certainly very subject to impactions. Continues through the right dorsal colon, the left dorsal colon, the diaphragmatic flexure, and then the right dorsal colon, and then into this area here, which is the transverse colon. Again, you can see that the diameter of the bowel is markedly decreased, and so that's going to again make this area quite subject to impactions. Continue through the small colon and then on out to the rectum. Another thing that I think is worth emphasizing here about this anatomy is that it's important to remember that the large bowel, which includes the cecum and the large colon, attach to the dorsal body wall only in this area near the base of the cecum and near the transverse colon. And so the cecum at large and most of the large colon is a very mobile structure, and that certainly gives it the ability to move around and get involved in displacements and torsions. The large colon would be the segment of the bowel that's probably most commonly involved in surgical colic. Most commonly, we're going to see impactions, and as I mentioned before, the pelvic flexure and transverse colon are most commonly involved because this is where the bowel decreases in diameter, and so it becomes a natural obstruction, or potential for natural obstruction, for that anatomical reason. Displacements are also quite common, and torsions are more common, or more properly, I guess, referred to as the volvulus of the large colon. These not only obstruct the lumen of the bowel, but also strangulate the bowel, and so unless these torsions are dealt with very quickly in a surgical manner, usually the bowel becomes devitalized and you end up losing the animal. Right dorsal displacements of the large colon are also very common, and this involves movement of the pelvic flexure, usually first of all in a cranial and dorsal direction. This process may continue to the point where the entire large colon wraps around the cecum, and obviously this is something that's going to require surgical reduction. Another very common displacement is a condition that we refer to as nephrosplenic entrapment. In this condition, the left colon becomes trapped between the left body wall and the spleen eventually migrates dorsally so that the left colon becomes entrapped in the space between the tip of the spleen and the left kidney. And the nephrosplenic ligament is the structure that holds the bowel in this position. And frequently this diagnosis can be made on rectal examination. Small intestine, fortunately, is probably less commonly involved in surgical colic than the large bowel. The things that we see involving the small intestine are incarcerations. And basically, this is just a situation where the small intestine, or a segment of the small intestine, becomes entrapped in an opening or a space within the abdomen. Some of the common sites of incarceration would be the epiploic foramen. Occasionally, a horse will get a tear in the mesentery of the jejunum. We're not really sure how this happens. There may be pre-existing inflammation in the abdominal cavity, which makes the mesentery weaker. It may result from external trauma. We really don't usually know ahead of time what causes these mesenteric rents, but sometimes a loop of small intestine will become entrapped in the mesenteric rent and require reduction and sometimes resection. Inguinal hernias are not uncommon in stallions, particularly standard-bred stallions, and this is a situation in which a loop of small intestine passes down through the internal inguinal ring into the inguinal canal, and sometimes will go as far as the scrotum. The small intestine is also quite subject to volvulus formation, and remember that a volvulus is rotation on the mesenteric axis, and various degrees of, or I should say, various amounts of the small intestine may be involved. One of the things that I should mention is that the ileum is certainly the most commonly involved segment of small intestine, so that usually if you open a horse's abdomen and you find that it's a small intestinal problem, in most cases you'll find that the ileum is involved to some extent. Okay, now we'll go on and talk about upper respiratory problems in the horse that require a surgical treatment. The first condition that we're going to talk about is left laryngeal hemiplegia. These horses are, of course, referred to as roarers. The condition is sometimes called roaring, and this is a result of the loud respiratory noise that these horses make during exercise. You remember from your anatomy that this condition involves paralysis of the muscles that are innervated by the left recurrent laryngeal nerve, and the diagnosis of this condition is made by endoscopic examination of the upper airway. This picture that you see here represents an endoscopic view of the horse's larynx. And just briefly, these two structures that you see in this area are the two arytenoid cartilages. This whitish line that you see here is the vocal fold, and this is the left vocal fold here. This area here is the laryngeal ventricle, or saccule as it's sometimes referred to, and this structure out here is the epiglottis, which is largely out of the picture in this particular photograph. The thing that I want you to notice in this picture is the asymmetry between the two arytenoid cartilages. This one on your left, which is actually the horse's right arytenoid cartilage, is able to abduct out of the airway when the horse inspires. The left one, however, you can see sort of hangs straight down here. This one is paralyzed. And whenever the horse inspires, there's a negative pressure created within the airway, and this has the effect of actually drawing this paralyzed arytenoid cartilage into the airway and across the midline in some cases, and actually will obstruct this opening to the larynx, causing the exercise intolerance that the horse is presented for. Okay, the treatments that have been used for this condition, first of all, probably the most simple treatment is ventriculectomy. This involves doing a laryngotomy on the horse and stripping out the mucous membrane lining of the ventricle so that it scars closed and hopefully will increase the airway as the horse is working. Ventriculectomy can also be performed endoscopically with a laser, and that's very commonly done now with the availability of surgical lasers. Another potential treatment is laryngoplasty in conjunction with ventriculectomy. Basically, the laryngoplasty involves the placement of sutures around the caudal board of the cricoid cartilage and also through the muscular process of the arytenoid cartilage, and as the sutures are tightened, this causes abduction of the arytenoid cartilage out of the airway and hopefully will improve the horse's ability to breathe and carry out exercise. The third most common treatment for left laryngeal hemiplegia is retinoidectomy. Retinoidectomy generally is considered mostly a salvage procedure, although some horses can go on and do competitive work with an retinoidectomy. Many of these horses are going to only be suitable for non-competitive work. The retinoidectomy basically involves taking out a large portion of the affected arytenoid cartilage, and this has the effect of increasing the lumen of the airway. Next condition that I want to briefly discuss is dorsal displacement of the soft palate. These horses are often presented to the veterinarian with a history of making a gurgling noise when exercised, and usually they're also showing signs of exercise intolerance. I found in my experience that often when you examine these horses endoscopically at rest, they don't actually demonstrate the signs of dorsal displacement, and so frequently to make the diagnosis we have to examine these horses while working on the treadmill. Endoscopically, this is what these horses look like at rest. And again, these are the two arytenoid cartilages here. This is the pharyngeal roof that you see over top, and this is the caudal border of the soft palate that you see here. You can see that the epiglottis is completely hidden from view because it lies underneath this soft palate. So when this horse breathes in and out, we now have this free border along the back of the soft palate that catches the air and causes ballooning of the soft palate as the horse breathes in and out. And of course, this is the cause for respiratory obstruction. The most common treatment for this problem is currently tonectomy of the sternothyroideus muscle, which is a relatively simple procedure to do. And in conjunction with this, we do a laryngotomy and grasp the caudal border of the soft palate and do what we call a staphylectomy, which is basically just trimming a small piece of tissue off of the back edge. Basically, the current theory about doing the staphylectomy is that the scar tissue that forms as this incision is healing, helps to stiffen the caudal bore of the soft palate enough to where it makes it more stable and improves its function. The last upper respiratory problem that I'm going to discuss with you today is epiglottic entrapment. And this is a condition in which the epiglottis is either partially or completely covered by redundant aryepiglottic folds. All horses normally have an aryepiglottic fold, but in these particular horses the fold is quite redundant, may be a result of chronic inflammation in the throat, but in any case the fold becomes enlarged and actually envelops the epiglottis sort of like a glove, and I'll have a picture of that to show you in just a sec. These horses again are presented for exercise intolerance. Some of them do have increased respiratory noise, and again the diagnosis is made by endoscopy. I think it's worth noting that this condition is often confused with dorsal displacement of the soft palate when these horses are examined endoscopically. And this photograph, which was taken endoscopically, may sort of give you a feel for why that happens. Again, we have the arytenoid cartilages up in this location here, and this is the epiglottis, which is covered by this mucous membrane, the aryepiglottic fold. And you can see that in some ways it does look somewhat similar to the last condition that we discussed, the dorsal displacement, in that this could be confused for the caudal border of the soft palate. The difference, however, is that you can see this crease around the edge of the covered epiglottis, and that usually tips you off that you're actually dealing with an epiglottic entrapment rather than dorsal displacement of the soft palate. Treatment involves resection or splitting of this membrane that is enveloping the epiglottis. Probably one of the simplest ways to do it is to take a hook through the mouth. This hook is about 2 feet long, and it's sharpened on the inside of the curvature of the hook. What you do is take your hand back into the throat. The horse is anesthetized under IV anesthesia. Palpate the entrapped epiglottis, place this sharpened hook within this entrapping membrane, and then pull it through to divide this membrane. And as the membrane is divided, it usually parts to both sides and retracts underneath the edges of the epiglottis. And so when you examine these horses post-surgically, you can usually again see the epiglottis sitting there. This can also be accomplished by using a laser through the biopsy channel on an endoscope, and basically what you do is take the laser beam under local anesthesia and split this membrane. Again, once the membrane is completely split, it will retract under the edges of the epiglottis. The thing that you have to use caution about on this procedure is that if you use the laser excessively, you may cause some damage to the epiglottis, but most of these horses will heal this up without any problem. Okay, now we're going to go on to some of the common lameness problems that we see in the horse, as well as some of the orthopedic diseases. And the first thing that we're going to talk about are subsolar abscesses, or as they're commonly referred to as sole abscesses. And these are probably without a doubt one of the most common conditions that equine practitioners will see in practice. The causes of sole abscesses are usually some form of puncture wound of the foot. Horse may step on a nail or a sharp rock, And certainly they may start out as a bruise. And we've also come to know the fact that horses that have chronic laminitis often have chronic recurrent sole abscesses as well. And so on these laminitic horses, this is something that you sort of have to keep a watch for, that if the horse suddenly has an episode of lameness, it may be a result of an abscess rather than a recurrence of the laminitis. As far as diagnosis is concerned, again, these horses will often come to you with a history of acute onset of lameness. They may have been completely sound the day before, according to the owner, and the next day they find that they're almost non-weight-bearing lame. Of course, when you put the hoof testers on these animals, they usually show quite a good localized response over the area of the abscess, so this can be quite helpful in making the diagnosis. They often have a black or discolored spot on the foot, and then if you want to do a nerve block and isolate it to the foot, isolate the cause of the lameness to the foot, obviously that's going to be very helpful in making the diagnosis as well. Okay, this is a horse that was presented for an acute lameness, and as you look at this picture of the bottom of the horse's foot, you can see that the foot's been pared down so that you can see a nice clean sole in this area. But as you look at the location of the two red arrows here, you can see that there's two discolored areas here that are sort of black, and some areas are actually a bit reddened. And this is an indication that these areas should be pursued a little bit further to see if they may lead to a subsolar abscess. The treatment involves paring these abscesses out liberally. Of course, this will be done under local anesthesia. Usually do a nerve block of the foot, and that will make your job a lot easier and certainly a lot more humane for the horse. Soaking of the foot may be helpful in terms of drawing the abscess to a head, but once the abscess is opened, I think you're probably wise not to soak the foot excessively, because sometimes this will cause swelling of the soft tissues and may actually delay healing of the sole abscess. Of course, once you've pared out the abscess, then you'll want to apply a protective bandage. And I've got a series of pictures here that sort of take you through this process. This is a case where the sole of the foot is being palpated. You can see that there's a reddish area between the farrier's two thumbs here. And what he's doing is palpating with his thumbs to see if he can detect whether or not there's separation of this cornified sole from the underlying sensitive sole. You can also take a probe. As you can see here, this is a blunt metal probe, and by inserting it into this opening, you can see just how extensive the sole separation is in this particular foot. Here the farrier is, this is actually another case, but it's very similar. Here the farrier is taking his knife and starting on this area that he suspects is the problem. And as he progresses, you can see that he's actually pared off quite a large area of separated sole. And I think it's very important to get this separated sole removed, because it allows the underlying sensitive corium of the sole to start to epithelialize again and then recornify. And as I mentioned, this is followed by a protective foot bandage, and this bandage, of course, is going to be changed on a daily basis or as necessary until the foot heals enough to where a shoe and a pad can be applied. Okay, the next condition that we'll talk about is one called thrush. And this is also a very common cause of lameness in horses. Usually the first thing that you'll observe when you examine the bottom of the foot is black, very foul-smelling material in the sulci of the frog, either in the central sulcus or in the lateral sulci of the frog. These horses are often lame, but not necessarily so. And the cause of these is usually associated with poor foot hygiene. So what happens is that you get an anaerobic organism such as Sporophorus macrophorus that establishes a foothold in this area and finds it's a very good place to reproduce and establish this infection that results in the thrush. Here's a picture of a horse that has thrush, and you can see that this foot is very badly overgrown. You can see how long its heels are, and so this horse has not had very careful hoof care over the last while. And you can see that this horse has a very distinct central sulcus in this frog, and you can see that this sulcus over here is also quite deep and filled with this black material. The treatment again would be to trim the foot out, make sure that it's cleaned. You can apply antiseptics and astringents to this part of the foot, and initially you will probably need to put a protective bandage on the foot. And so this would be a situation where you need to discuss with the client improved foot care. So this horse should probably have its foot inspected on a daily basis and cleaned out as necessary. The next lameness problem that we're going to discuss is laminitis. And this is a disease that has had a lot of research conducted on it recently over the past 10 to 15 years. Unfortunately, a lot of the research results have been conflicting, but I think everyone would certainly agree that laminitis involves alteration of blood flow to the foot. And usually these horses will present with an acute lameness or acute pain situation, and once you get them through the acute phase, they usually progress to a chronic lameness problem. This condition is predisposed by quite a number of things. I think most people are familiar with grain overload, which results in a heavy overdose of carbohydrates. We often see laminitis associated with foaling, particularly if there's retained placenta. We see it with endometritis. Interestingly, we often see it associated with colic and endotoxemia, but it's also been shown that when endotoxemia is induced experimentally in horses, that it doesn't cause laminitis. Trauma can also be a cause of laminitis, and this is could be a situation in which a horse is worked on a very hard surface without adequate foot protection, and so the trauma to the germinal lamina of the foot may result in enough inflammation that the horse ends up with what some people refer to as road founder. Quite a few years ago, with the abundance of black walnut shavings, people thought that this would be a good thing to try to use as bedding for horses, and then it was discovered that it causes laminitis. And so this is pretty much general knowledge, but occasionally there is an episode of black walnut shavings induced laminitis that occurs. And then last of all, just any circumstance or situation that causes stress for the horse may result in laminitis. So many cases that are presented to the veterinarian for treatment of laminitis, the horse's owner may give you a very careful history, but there may not be anything in that history that really is an indicator to you what the specific cause is. This is a foot that shows some of the features that are very typical of chronic laminitis. You can see that this foot has sort of a dished out dorsal wall. You can see that it has very marked rings as you go down the hoof wall. And as you follow these laminitic rings, or some people refer to them as growth rings, you'll notice that as we get closer to the quarter or the heel of this foot, that these rings start to diverge down more distally in this direction. That's because there's more distance between the rings in the heel area than there is up in the toe area, and that's a result of slower growth in the toe area because of the damage to the lamina in this area. As a result, you get this dishing of the dorsal hoof wall. People refer to rotation of P3, or the coffin bone, within the hoof capsule, and this is a lateral radiograph of the foot of a horse that has chronic laminitis. You can see that when you compare the angle between the dorsal hoof wall and the third phalanx, that there's obviously been rotation, so that the distance down here distally is much greater than up here. The rotation of P3 is thought to occur as a result of the pull of the deep digital flexor tendon, which inserts in this area here, so it has a caudal pull in this direction. Of course, every horse has this tendon, and rotation doesn't occur. The reason that it occurs in the horse with laminitis is because there's been damage to these lamina that hold the bone within its normal position within the hoof capsule. And when these lamina are damaged, they can no longer resist the force of the deep digital flexor tendon, and therefore P3 rotates within the joint capsule, within the hoof capsule rather. Another condition that can occur with laminitis is something that we call sinking. And what happens in this situation is that the third phalanx actually drops straight down within the hoof capsule rather than rotating within it. And one of the clinical signs that we see in these cases is that the horse will have a depression at the coronary band, as is shown in this picture, so that if you take your finger and run it down the front of the pastern, when you get to the coronary band, you feel this ridge or trough around the coronary band, and that's an indication that this horse has laminitis and that he's actually sinking. Radiographically, these horses look somewhat different than those horses with rotation, in that you see that this horse has a very obvious coronary band on this radiograph. Normally it's not so obvious on a lateral view. And also the distance between the dorsal hoof wall and P3 is increased. This should not be in excess of 20 millimeters, and this horse had a distance that was about 25 millimeters. So that was also an indication that this horse had sinking of P3. Treatment for laminitis involves a number of things. If you're dealing with the acute phase, of course, phenylbutazone or other non-steroidal anti-inflammatory is always administered. Acepromazine is often used as part of the treatment. These horses often have peripheral hypertension. The acepromazine does help alleviate that. DMSO is often given as a superoxide radical scavenger. Nitroglycerin paste is often applied to the digital arteries to improve perfusion to the feet. Some people have felt that this might have a preventative effect, but I don't think anybody's ever proven that. But certainly it does have therapeutic value in some cases. Quad support and protective bandages are often used in the initial treatment of acute cases. In subacute cases, or chronic cases, again, we rely very heavily on phenylbutazone to provide pain relief for these horses. Weight loss is often an important part of the treatment because frequently these horses will be quite overweight, sometimes as much as 200 or 300 pounds. And obviously this excessive body weight is going to increase the load on these laminitic feet, and so weight loss is going to be a critical part of the treatment. Many of these horses are cushingoid, and so the use of cyproheptadine is often very helpful in these cases, and frequently within a few days of beginning cyproheptadine treatment, these horses will show considerable pain relief. Deep digital flexor tonectomy or tenotomy is also recommended as treatment for these animals. We used to just think of this as a salvage procedure, but interestingly, a number of horses that we have cut the deep digital flexor tendon on for treatment of laminitis have actually gone back and returned to performance. And as I mentioned before, the deep digital flexor tendon exerts this pull on P3 to cause the rotation, and so by transecting the tendon, you alleviate this tension and provides considerable pain relief for the horse. I would also mention that once the tendon is cut, the ends do heal back together again, but the length of the tendon is longer than it originally was, and so this helps to allow the angle of the coffin joint to go back to a more normal angle. Another approach to the treatment of chronic laminitis is therapeutic shoeing. Hoof wall resection is frequently done in these animals. If you've got hoof wall separation to where there's a large area that's filled with serum between the sensitive and non-sensitive lamina, it's important to open this area up so that it can start to epithelialize again and then again recornify. And there's a number of different types of shoes and tabs that are used on these horses. Egg bar shoes are quite commonly used. This is a horse that has had a hoof wall resection, and you can see that the dorsal hoof wall has been fairly liberally excised in this area. And what the farrier looks for as he's doing this is to get this resected back to the point where there's no longer separation and fluid accumulation in this area. So when you start seeing some blood, that's an indication that you have live tissue, and that's certainly a good sign. As radical as this appears to be, it allows the foot to start healing again, certainly relieves a considerable amount of toe pressure on the horse, and this certainly is a very common procedure that's done to help get these horses back on the road to recovery. This is a horse that had rotation of P3 within the hoof capsule and has had a dorsal hoof wall resection. You can see that the foot's been trimmed down in this area, and so it's helping to realign the foot capsule or the hoof capsule to P3. It's important for you to understand that once rotation of P3 occurs, you can't move P3 back forward within the hoof capsule. What you have to do is reshape the hoof capsule so that it fits or it's positioned appropriately with P3. This is a horse that's been shod with an egg bar shoe. You can see that the shoe goes all the way around. thus the name egg bar because of its egg shape. And this horse has been shod with something called an equipack pad. It comes as a liquid that is put into the sole area after the shoe is applied. This liquid sets up and forms a very rubbery material that provides good cushioning for the horse and provides considerable pain relief. Okay, now we'll go on and talk about some orthopedic problems that lie in the group of diseases called developmental orthopedic disease. First condition that we'll talk about is osteochondritis dissecans, or OCD as it's commonly referred to. One of the most common sites of OCD formation in the horse is the lateral trochlear ridge of the femur, as is shown by this red arrow. And the treatment for this would most likely be arthroscopic debridement of the area. And this would heal in by formation of fibrocartilage. The prognosis for these horses to return to soundness is usually quite good. Another common site of OCD formation would be the distal intermediate ridge of the tibia. And as is shown by this red arrow, there's a fragment lying within this area here in the joint. And again, arthroscopic removal and debridement of this area would be the most likely treatment. And these horses also carry quite a good prognosis. Subchondral bone cysts are another aspect of developmental orthopedic disease. And the most common site in the horse for the development of subchondral bone cysts would be the medial femoral condyle. And this is a weight-bearing area compared to the last two conditions that we saw, OCD in the lateral trochlea and the distal intermediate ridge. These subchondral bone cysts usually result in a considerable degree of lameness because the horse is bearing weight on this lesion. Most commonly, these are treated either by conservative therapy. The horses are rested, treated with anti-inflammatories. Horses that don't respond to that are usually treated by arthroscopic debridement of the area. And the prognosis on those horses is usually about 50%. Another aspect of developmental orthopedic disease is angular limb deformities. And most commonly, we see this problem affecting either the carpal or tarsal joint, so that we see either carpus or tarsus valgus or varus. And this is kind of an interesting case, often referred to as a windswept foal. You can see that this foal has carpus valgus on the left carpus and carpus varus on the right carpus. And so you sort of got the opposite problem in each forelimb. Looking at this foal radiographically, it's important to try to determine the actual source of the cause of the deviation. Probably most commonly, you're going to see this as a result of soft tissue laxity. See it particularly in young foals that have laxity of the collateral ligaments of the joint. And usually these animals will grow out of the condition if they are given enough time and their exercise is restricted. In this particular case, however, we've got a number of orthopedic problems that are contributing to the angular limb deformity. This foal has some degree of compressional fasciitis, particularly here on the left limb, and you can appreciate a very small amount of epiphyseal wedging here on the lateral aspect of the distal radius. But some other things that are worth noting is that there are some changes in the carpal bones, actually in both carpi. If you compare the fourth carpal bone in this carpus with the one over in the right carpus, you can see that this one is somewhat wedged compared to the longer size over on this side. Likewise, the second carpal bone on the medial aspect of this joint is wedged compared to the one here. So what's happening is that we've got compression of the carpal bones on the lateral aspect of this joint and on the medial aspect of this joint, resulting in the angular deformities that you see over here. There have been several treatments that have been described for angular limb deformities in foals. The most common would be periosteal stripping or periosteal transection. And the idea behind periosteal stripping is to try to increase the growth rate on the side of the limb that is growing more slowly. So in this case, the lateral side or the concave side is the side that you want to speed up. So you'd make a small incision on this side of the limb here, and with your scalpel you would transect and undermine the periosteum in this area. That relieves the periosteal tension and allows this side of the bone to grow more rapidly and thus straighten the bone out. Another treatment would be transphysial bridging. That's done on the side of the limb that is growing more rapidly, or the convex side of the limb. In this case it would be the medial side. So this growth plate on the distal radius can be bridged either with a staple or by putting 2 screws and a wire across this area here to slow down the growth. Another possibility would be external coaptation, such as a cast application, and that would help relieve the compressional pressure on these carpal bones in this area. Another aspect of developmental orthopedic disease would be flexural deformities, and the most common one that we see in the horse is a flexural deformity of the coffin joint, often referred to as a club foot. If you compare these 2 feet, you can see that this left foot is really quite normal in size and shape, whereas this right one has a very steep dorsal hoof angle and a very high heel. And if left long enough, these horses usually become lame. The treatment for this is to do an inferior check desmotomy. And this diagram depicts, first of all, on the left side, the normal anatomy. So we've got a normal hoof axis here. There's no evidence of a club foot. Compare that with this one where we've got a broken foot axis. So we've got the flexural deformity of the coffin joint here. Again, this is caused by the pull of the deep digital flexor tendon. So to relieve this excessive pull, what we do is transect the inferior check ligament here, and that allows the foot to take a more normal angle. And in addition with that, we would trim down the heel. If there's excessive toe wear on this foot, we'd probably build up the toe either with a shoe or some acrylic. Okay, another lameness problem that I wanted to make you aware of is Sweeney. This is one that many people are aware of, but interestingly, very few people have actually seen a horse with Sweeney. And Sweeney is a result of injury to the suprascapular nerve. This is usually due to direct trauma over the cranial aspect of the shoulder. A lot of times the client will come in and say that they actually saw the horse run into something out in the pasture, or may actually have 2 horses playing out in the pasture and they run into each other and they both develop the condition at the same time. And I've seen a number of episodes of that in my career. The clinical signs are atrophy of the infraspinatus muscle and supraspinatus muscle, as well as abduction of the shoulder joint during weight bearing. I have a picture here of a horse that shows this atrophy. You can see that the shoulder joint is very obvious, and this white line that you see running down the center here is actually the spine of the scapula, you can see that there's very little muscle mass here where the supraspinatus muscle should be. Now I have a short video of this same horse walking that shows the abduction of the limb as the animal walks. You see that as the horse becomes weight-bearing, this shoulder actually pops out laterally or abducts. And this is very typical of the Sweeney condition. Treatment involves relief of pressure on this nerve. Usually what happens is that the nerve becomes entrapped by fibrous tissue where it comes around the cranial aspect of the scapula. And a procedure that's been described is to actually take a notch of bone out of the front edge of the scapula to relieve this pressure. You can basically achieve the same end by just dissecting the scar tissue away from the nerve, and most of these horses, after having surgery, carry quite a good prognosis. It usually takes several weeks to several months for them to return to soundness, but most of these horses will return to function. Okay, now I want to talk about surgical problems associated with the reproductive tract. And I think most people are familiar with castrations in the horse. And what I wanted to do was spend just a couple of minutes making you familiar with some of the complications that occur with castration in the horse. The first one, and certainly the one that is going to be the most acute after the surgery is done, is excessive hemorrhage. Here you see a horse that has been castrated. It's recovered from its intravenous anesthesia, and you can see that the stall floor under the horse is covered with quite a bit of blood. Most of these horses can be dealt with while they're standing, either by packing the scrotal incisions with gauze. Occasionally you can even see the source of hemorrhage and place some hemostats on it and do a ligature. If the horse is not cooperative, or you can't actually find the source, you may have to re-anesthetize the animal and take care of it with the animal under anesthesia. But in most cases it's a problem that's fairly easily resolved. Another possible complication of castration is evisceration. This is a situation in which, after the animal recovers from the intravenous anesthesia, there's evisceration of usually small intestine or omentum out through one of the incisions. This can occur immediately after the castration, or it can occur as late as a day or two after. But usually there's enough swelling that occurs after the surgery that if it doesn't happen immediately post-surgically, then you don't have to worry about it. One of the things that I like to do on castrations is I routinely palpate the size of the vaginal ring at the end of the castration, just to make sure that it's not large enough to allow intestine to come out through it. If it is, then I usually put a couple of sutures in it to prevent this from happening. Excessive swelling of the scrotum and the sheath area is probably the most common post-castration complication, and it usually results in many phone calls from the client. They're usually very concerned about the animal. Occasionally these animals will spike a fever, and they may become reluctant to move around and reluctant to eat. And certainly in those cases, I think that they do need some attention. If the swelling has progressed to the point where it's actually sealed off the scrotal incisions, then it's probably important to place a gloved hand within the surgical incisions to reestablish drainage. And usually that's all that is required to take care of this problem. Other thing that's going to be important is to have the owner make sure that these animals are exercised, and occasionally using hydrotherapy on the swollen area will help as well. Usually antibiotic therapy is not going to be required. Another complication of castration is the formation of a spurous cord. This picture depicts a horse that has had a castration. It's actually anesthetized on dorsal recumbency. This is the remnant of the scrotum here, and this white material that you see here is purulent drainage from one of the castration incisions. So what's happened is that this horse developed a chronic infection in the surgical site. It became surrounded by a considerable amount of scar tissue and resulted in this chronic draining tract. And so the only way to deal with this is to anesthetize the horse and dissect this infected material out completely, and then allow it to heal in by second intention. Another potential complication of castration in the horse is the formation of a hydrocele. And this picture represents a horse that is now under anesthesia, dorsal recumbency. This horse was castrated several months prior to this, and after the horse had apparently healed up from the castration, the owner noticed that it had what appeared to be testicles in the scrotum. And when these masses or swellings were palpated, they were found to be fluid filled. And you can see one on this side that is filled with fluid. You see emasculators over on this side, so this side's already been taken care of. But when this area is dissected open, basically what you have within is a remnant of the tunic that has to be stripped out. This is producing fluid, may also be communicating with the peritoneal cavity. So once this is all dissected out, these horses will usually heal up without any problem. Okay, one of the common surgical problems that we see associated with the reproductive tract of the mare are third-degree perineal lacerations, also referred to as rectovestibular lacerations. These are usually seen in mares during first foaling. And what happens is that as the mare is trying to expel the foal at the time of parturition, one of the foal's feet gets pushed up through the dorsal vaginal wall or vestibular wall, punctures through into the rectum, and then as the foal is expelled by the mare, this foot will actually tear out the perineal body. And so as you can see in this picture, here's the anus up here. This pink tissue that you see right here is the rectal shelf. So the lumen above it is rectum, the lumen below it is the vestibule, and this other tissue that you see across here is the remnant of the hymen. Surgical repair is usually done in two stages. The first one is an attempt to reconstruct the rectal vestibular shelf, and then once that is healed, you usually try to reconstruct the perineal body. which includes skin tumors and neoplasia. This sort of granuloma that you see on this horse's leg are a very common occurrence in equine practice. And of course, when you're presented with one of these cases, it's going to be very important for you to try to diagnose what the problem is so that you can treat them appropriately. Some of the things that you should think about when you see this sort of granulomatous mass are, number one, exuberant granulation tissue or proud flesh, and this is going to be probably one of the most common causes of these kinds of masses. Sarcoids are certainly the most common skin tumor in the horse, and frequently will have the appearance of proud flesh. So just looking at them superficially, it may be very difficult or impossible to distinguish between the two. Squamous cell carcinoma is also a very common skin tumor in the horse, so that should be on your list of differentials. And particularly here in the southeastern part of the country, we see a lot of phycomycosis or pythiosis, sometimes referred to as Florida leeches. These are fungal-like organisms that establish an infection within the tissues, usually in a pre-existing lesion, but not necessarily so. And diagnosis is usually based on histopathology, and also culture can be quite helpful in these situations. Haberdemiosis or summer sores should also be on your list of differential diagnoses. Haberdemiosis has become very common again. For quite a few years when we had ivermectin, it seemed like this condition had almost disappeared, but now it appears that the organism is becoming resistant to ivermectin, and so we're seeing quite a bit of it again in the last year or so. Histology is probably going to be very useful in the diagnosis of this condition. Well, I see that my time is up. I've enjoyed talking with you. I'll look forward to our question and answer period, and I would like to tell you that any questions pertaining to equine surgery are fair game during the question and answer period, and I look forward to seeing you then. Thank you.